Hello everyone, this is Chadi Alraies from SCAI 2023 in Phoenix. I'm really privileged today to be with Dr. Arnold Seto, who's been Vice Chair on the document that came out from SCAI related to ASC and also performing PCI and with no surgical backup. Dr. Seto, thanks for being with us.
Yeah, thanks for inviting me.
Yeah. So we read your document that came up, great paper giving a lot of guidance. But tell us about where this idea came from and how's the impact of this document.
Yeah, this SCAI PCI without cardiac surgery backup document was published in JSCAI just in January. It was led by Cindy Grimes, our past president, and she wanted to update. She was on the document committee in 2014, the last time SCAI commented on the safety of PCI without cardiac surgery backup. And at that time, that document set out several restrictions. They suggested that patients who are high risk or who had high risk lesions should not be done in hospitals without cardiac surgery backup. And unfortunately, over time, the evolution of PCI has been such that it's been demonstrated that PCI without cardiac surgery backup is largely safe with an estimated rate of emergency cardiac surgery of only 0.1%. Meanwhile, in Britain and other places, they've demonstrated that cardiac surgery backup is a bit of a misnomer. A study in Germany actually determined that it took them on average 180 minutes to activate the cardiac surgery suite, and even if you had on-site surgery. So the reality is, emergency surgery is really not your backup. It's you still have to resuscitate the patient, rescue the patient, stabilize the patient before you transfer. Granted, it takes up to 5 hours to transfer a patient and get them to cardiac surgery. But the reality is, if someone needs revascularization emergently, then your best shot is not to transfer them to a cardiac surgery center, but rather to just manage them there, try everything you can, and support them with both support devices like balloon pump and Impella, possibly ECMO, but also revascularize them as best as you can percutaneously. Yeah. So this current document we have reviews all the evidence that's been accumulated since 2014 that have demonstrated the safety of cardiac surgery, of PCI without cardiac surgery backup. And it comes to the conclusion that we should really adjust what we do based on the capabilities of the center. So we laid out several types of centers. One is an ASC with no hospital services, no vascular surgery, no blood, no labs. In those cases, anybody who, of course, needs potential blood transfusion or vascular surgery backup, they shouldn't be done there. If you have a PCI, a level 1 PCI hospital where you just have a balloon pump, but you don't have other like 24/7 ICU and you have no other bailouts scenarios, then you should stick to relatively low risk lesions on patients who don't have LV dysfunction, for example. But a large number of hospitals these days, they formerly had cardiac surgery, they have Impella, they have lithotripsy and rotablator. These types of hospitals are perfectly capable of managing the vast majority of PCIs, and so we set out a fairly open set of criteria which indicated that most lesions could be handled by such hospitals.
Yeah, and this is given, as you mentioned earlier, is about more prompt care for these patients and not to deprive them from a therapy that they need, so they end up with kind of questionable, lousy results.
Yeah, right, exactly. I think it really becomes more evidence-based. I mean, yes, in the past it was the rates of emergency cardiac surgery was 20% when we started PCI 40 years ago, but that's 40 years ago. The reality is that data these days have demonstrated a very low risk of emergency surgery, 1 in 1,000, and that actually if you were done at a cardiac surgery center, you had more emergency surgery, maybe because you're taking on higher risk lesions, maybe because emergency surgery was available.
I see.
So, the data...
Because you're already doing the surgery on site, you have the courage to do more.
Right.
So people are already doing risk stratifying the lesions, but now this document kind of make it more streamlined.
Yeah. We have of course the MASCOM trials, the randomized trials, 2 randomized trials that show that there's no difference between on-site cardiac surgery backup and transfer. But those were lesions that were limited to non-left main and things and LV dysfunction. But the evidence has accumulated that shows that it's equally safe. Now, this is not a license to be taking on, too many lesions. We specifically mentioned the extreme case of epicardial retrograde CTOs. You should not be doing those in a non-cardiac surgery hospital because there's a risk of perforation, and then you need cardiac surgery. So it's not a license to do everything, but it is a license to say the evidence shows that with careful selection and judgment, and an experienced operator, most importantly, an operator that's actually trained at a cardiac surgery center who knows what the surgeon is capable of and is able to. In those situations, then clinical judgment can proceed based on the evidence.
And Dr. Seto, you mentioned offline that there is this document getting attraction from state laws as well.
Yeah, so since publication, even in February, I already was approached by the California regulator for PCI without cardiac surgery, and he indicated that California at least will be following SCAI guidance. So, and I can describe the California experiences is that at all hospitals without cardiac surgery, they were not allowed to have a rotablator or atherectomy devices available, because at the time the concern would be that you would have more dissections or trap burrs and so on. And those are certainly are possible, but the converse of that is that when you don't have atherectomy, then the lesions aren't as well prepped. You're going to have a higher chance of roto-regret or a dissection from a balloon angioplasty of a calcified lesion. And we all know that proper lesion preparation actually makes the PCI safer. So that's definitely the converse case where being overly cautious with the atherectomy devices actually can make care less safe. So in that regard, I think we actually can make care both more available and more safe.
Absolutely.
Yeah.
Well, thank Dr. Seto and Dr. Grimes for putting this together, which can, as I mentioned, streamline the process and bring comfort to the administration in the hospital as well as physician treating patients who don't have a surgical backup. Watch these videos and others on SCAI TV. This is Chadi Alraies from Phoenix. Dr. Seto, thanks for being with us.
Thank you.